questions. And it's really an honor to be back. And the base access office part is my favorite part, standing in the office there. But I hope, first of all, given the time of the lecture, you'll stay awake. I have many pictures that will maybe cause you to wake up, and we'll go through some really important things in dermatology, such as morphology. What does the rash look like? And the second key word for you guys is distribution. So what does it look like, and where is it distributed? Those are basically keywords for derm. And at least I think my goal is that you're not getting the right diagnosis each time, but at least you're thinking of the list of what it could be, and you know what to Google. Okay, so these are pictures I took when I was a resident myself, and I was very excited as I spent the first training weeks of my training career in East Africa. So a lot of the pictures are from my mentors, from myself, and please don't share them. I have blocked out patient spaces. I know you get PDFs, so be careful with what you share, no matter where these pictures are from. And in the background, there's Mount Kilimanjaro over here, and in Tanzania, and those are pictures I took. And I think my skills are better every year, I hope. So I don't have any conflicts of interest. And my interest area is within global health, and within global health, especially neglected tropical diseases and skin manifestations, which is what brought me to this course in the first place. And to wake you up, tropical things are not only tropical medicine, tropical, we have some pictures of tropical fruit, tropical birds, all kind of tied into tropical medicine at some point. Some of these things carry some vectors and stuff, so exotic plants, we love traveling to tropical areas. As a dermatologist, I'm always ranting about sunscreen use, so my lecture kind of spoils travel and fun for everyone, but hopefully it won't be as scary. And exotic journeys, we've loved as humans taking journeys as far back as BC and AD in history. Two historical figures I love reading about in school were Alexander the Great and Marco Polo. I actually was born here in the United States, but I grew up in England and in Pakistan, so I'll show you how that sort of, and worked in East Africa, so that kind of tailored my interest in all things tropical and things people can get by travel and other means. So, Alexander the Great and Marco Polo, a warrior and a trader. So they traveled to exotic lands, and the military has a huge history in tropical medicine. And why are you all here during this course? Because you might be situated in some place where you will need to know what diseases are endemic, or you might have people who come back to you after learning certain places and present with certain diseases. So Alexander the Great is of huge interest to me, as his kingdom actually extended into what's present-day Pakistan, where I grew up, and a city called Lahore. And anybody know what stopped Alexander's conquest finally? What disease is postulated? What's the one thing that should always be in your defense? So it's postulated that Alexander actually died of malaria, and this is an article I found, and some people argue maybe it was typhoid, but some others argue that it was malaria, and described in the symptoms historically. This is Pakistan, the northern areas. I just put a picture up there. It's a beautiful remote part of Pakistan in the northern mountains, and it's the people of Kailash, or in the northern areas, that is believed are descended from the Greek invaders. So beautiful area if you're brave enough to venture there. And coming back to the United States, as a melting pot of different cultures, different waves of immigration here, different waves of major immigrant groups flocking to different cities, I think it's more pertinent to describe it as a salad bowl rather than a melting pot. If you look at DC, Chicago, New York City, you have distinct neighborhoods. There's actually patients I would see. I actually just moved from the University of Chicago just back to the East Coast again a few weeks ago. And she Chicago, there's patients you would see from Chinatown who just wouldn't speak English, having lived in Chicago for many, many years, and I thought it was crazy, but it's true. You have distinct neighborhoods, you have distinct Greek town, Chinatown, but the Indian and Pakistani neighborhoods. So it's amazing that we need to know where somebody grew up, when did they come, and certain incubation periods for some of the things we'll study. That's where it's pertinent to take that history of travel and where did they grow up. Travel spreads diseases, as you guys know. Millions of international travelers from the U.S. going outside. What were the top travel destinations? You could run your eyes through this list, and a lot of these places are in tropical areas. And these are the top cities of origin. You're actually in one of these, near one of these cities. So DC is one of the ports of origin for travel. War takes us to different places where certain conditions such as leishmaniasis may be endemic. Our troops have close contact sometimes with the locals. And then refugee movements. This is another huge interest area of mine. And refugee health, and I worked actually with Syrian refugees over the last 2 years, and I saw a couple of cases of leishmaniasis. So again, like refugee movements, not only when we're over there caring for them as a military diplomacy mission, or we have refugees resettled over here. So you have huge refugee populations in cities like Minnesota, like Somali refugees, and in San Diego. So again, you might be seeing some of these patients also. So these are refugee arrivals of 2008 to 2010, from which countries they were arriving. And then again, in 2015 to 2016, and Africa made a huge chunk of where the refugees were arriving from. Legal permanent residents or green card holders, over 1 million people became legal permanent residents of the U.S. And then again, this list goes over about where the countries and continents were from, and again, a lot of tropical areas listed here. For those of us who do believe in this, and so environmental change may lead to vectors, as you know, spreading, and mosquito-borne illnesses we're seeing more and more. We used to talk about dengue more than a decade ago. We're going to see it. It's coming, and it's here. So, and as you all know, the same mosquito species carries other diseases in our major airports. It's amazing. You see Zika, chikungunya signs everywhere, which a decade ago we didn't even think about it. But in this course, they were thinking about it even back then. So, exotic disease, not so exotic anymore. These were more than a decade ago. The deadly dozen diseases environmentalists predicted would be increasing in frequency, and we would be seeing these more and more. Movies have been made, giving a scary edge to this stuff. And then what about skin disorders? So in travel clinics, actually, in studies done around the world, this is one of the older ones, still skin diseases remain in the top 5 things seen in returning travelers. And if you break them up, the most common things are bacterial skin infections like pyodermas, insect bite reactions, cutaneous larval migrans, and leishmaniasis from certain endemic areas. So that's the tropics. That's what all the course is about. This is me, much younger, no Botox or anything, I must say. In the annual military picture, I do have more gray hair, I see every year as I take the picture. So this is a park ranger in Kenya. And I show this picture because he said, you're a dermatologist, so you diagnose a skin rash by looking at the skin. I diagnosed what animal was there by looking at the prints on the ground. So he was quizzing me, and he showed me a paw print, and he said, you guess what animal this is. So again, keywords for dermatology, morphology, and distribution. The morphology is a paw print, and the distribution is it's a park, safari park in northern Kenya. So what animal is this? How many people say lion? How many people say elephant? How many people say rhino? Right, it is a lion. So it's so this picture is good in the morphology and distribution. So that was a picture I took. Very proud of this picture, and then the word for lion in Swahili is Simba. And there was Simba, he was honeymooning with Mrs. Simba a few yards down, and Barclay was pretty happy with himself that he taught me something. So we're going to go through different morphologies in dermatology. Now I want you to get rid of the term in this course of maculopapular. I will say that what irritated dermatologists is using the term maculopapular. If you just use the term morbilliform, they'll be impressed by you right away. It doesn't take much to impress us, I guess. So morbilliform is measles-like, and it is maculopapular. So macules that are flat lesions, less than a centimeter, and some papules which are raised lesions more than half a centimeter or a centimeter. So that's your differential within morbilliform. This is tailored to what you would commonly see in the tropics. This is the classic morbilliform eruption. Another key point to remember about morbilliform eruptions is that when you see one, don't be afraid to touch it. You can wear gloves. Other key thing to remember in dermatology, see the rash first, then shake hands. Okay, so always leave the residue cyst, and you won't be freaking out afterwards. And you run your hand over the morbilliform eruption. The reason you're doing this is it blanching or not? If it's blanching, you're good. Okay, if it's non-blanching, you're more in the purpura category there. The second thing with the morbilliform eruption is, first, touch it, see if it's blanching. Second thing, look at mucosal sites. Are the mucosal sites involved or not? And if it's a drug rash, mucosal involvement will signal you more towards worrisome things like Stevens-Johnson syndrome. And then the touching, the skin sort of curls away, that brings you into the category of toxic epidermal necrolysis. So those are important things to remember with every morbilliform eruption. The third thing is to look at the palms and soles. That's where the shaking of the hands comes from. And so, touch it, mucosal involvement, and are the palms and soles involved or not? And you can differentiate. This is very rare. It's the HIV seroconversion exanthem. In dark skin, it's very hard to appreciate. And most of the time, you see this when it's desquamating as dry skin. And you know that there was something that inflamed the skin, and you're just seeing it as an exfoliative dermatitis. This is a morbilliform drug reaction. It's getting to be more confluent on the trunk. The second morphology is erythroderma, all red. Basically, the skin is all red, and atopic dermatitis, drug eruption, lymphoma are on the differential. This is erythroderma. This can start off as morbilliform and become all red. This is usually something you hospitalize patients for. Clues you look for, you look at the nails, you look at mucosal sites for drug eruptions. Psoriasis can cause this too. This is the exfoliative part of the erythroderma. This is not something like toxic epidermal necrolysis where the skin comes off like a burn. Here the skin comes off and you have normal skin under it. So nothing super worried about, just emollients to be used. Third morphology, papules and nodules. Papules, raised lesions, 0.5 to 1 centimeter, and nodules more than 1 centimeter raised lesions. Huge differential in the tropical derm section that are listed here. One of the big ones is ecthyma. These are nodular lesions on the legs, infection by Staph aureus, very common in the tropics. Other thing in the differential tropical ulcers, which are multibacterial in nature. And then purple violaceous nodules, especially in countries with high rates of HIV. This is still seen Kaposi's sarcoma. So purple violaceous nodules. Verrucous plaques and papules. So the top thing in verrucous, papules, and plaques is just warts. Other things can be verrucous carcinoma, verrucous HSV, and this is something that if you see verrucous HSV, it's acyclovir resistant. And then TB can cause wart-like plaques in some of the areas where TB is endemic. This is a specific kind of presentation of TB in the skin. It's called TB varicosa cutis. This is quite often seen in India and in East Africa especially. Everywhere the appetite is still fine, there's more to come. I've seen some faces, so just gear up, hopefully not a heavy lunch. Okay, verrucous plaques on the legs, again, chromoblastomycosis. This is huge in the differential. If a patient presents you with huge verrucous plaques that are disfiguring on the legs, chromoblastomycosis is on your differential. Another thing on the differential is a type of stasis dermatitis that causes wart-like plaques. When biopsied, chromoblastoma actually shows fungal yeast forms or proper pennies seen in the tissue when biopsy is available. This is one to memorize and to know. So this you will see in dermatology clinics and the tropics, umbilicated papules. So papules that have a central dell. So molluscum contagiosum, histoplasmosis, penicillium rhiniferi, and cryptococcosis. So these are the top things to remember with umbilicated papules, especially in the setting of HIV. You can see disseminated cryptococcosis pretty commonly. These are all umbilicated papules. If you see this one, you see that central right pore? That's what's umbilicated papules. So if you see a shower of them, crypto, penicillium, and histo should be in the differential. Folliculocentric. All it means is the morphology is going towards follicles. This is more evenly distributed, so you get folliculitis, which can be bacterial, fungal in nature, and then eosinophilic folliculitis that's seen in the setting of HIV. Vesicles, so blisters, large ones, small ones. So bullae are just large blisters, and those filled with pus are called pustules. One of the most common things seen is pyodermas or bullous impetigo caused by staph and strep. And then herpes simplex virus and herpes, the vesicles will be clustered. And then zoster, they will be most likely dermatoma. This is bullous impetigo with the purulent material at the base. Herpes zoster, following dermatomal distribution. In darker skin, the vesicles are more tight looking. So if you have a needle at hand, always wipe with alcohol and try to make the mix so you see if it's a vesicle versus a vacuole. And then in zoster, there's always that midline dermatomal distribution. And then a zoster can become hemorrhagic sometimes and purpuric, so that's just a presentation of it. We would not treat it any differently, still with antivirals. And then I wanted to show you this because this is a picture of a Maasai tribesman, and this is zoster again. So you won't see the vesicles or the bullae. You'll see actually when it's all the erosions that are crusted, but it still has that midline drop off, right? And then the worrisome thing in here is zoster, this involvement of the nasal tip or the side of the nose. This is called Hutchinson's sign. When you see involvement of this area, you are worried about ophthalmic involvement. So you have to get ophthalmology involved right away. So this is something I just wanted to point out when you see this and the side of the nose involved. This is a picture lending to me one of my professors from the London School of Hygiene and Tropical Medicine. It's really hard to find a picture of cutaneous anthrax. So this is again starts off as a vesicle or a bulla. But with anthrax, the key thing is the central black S-jar and the surrounding edema. So when you see central black S-jar with surrounding edema in the right setting, think about cutaneous anthrax in that setting. Pruritus. How many of you have had itchy patients? Okay. So this is one of the most common and maybe most frustrating things in dermatology. So number one cause is still in the tropics is dry skin or eczema. So common thing to be common, think about that and just gentle skincare and washing the skin without soap sometimes. And then scabies and urticaria and insect bites. So these are the top 4 causes of, I think, itchy skin in the tropics. I put insect bite here, so you think about insect bite always when it is exposed areas and then clusters of vesicles or vacuoles. So on the legs and dorsal feet and then on arms, and usually they stop at the t-shirt, and sometimes in the tropic people sleep without the t-shirt on, so you can see them in the frontal area too. So how do you differentiate scabies? So there's this great documentary actually on Netflix. It's called Fire at Sea. Has anybody seen it? So it's about the refugees that arrived at the Italian island of Lampedusa. And it was nominated for the Oscar last year. Total diversion, but I have a point here. So they show the physician who's filming this documentary as he examines the refugees as they get off the boat. And I was thinking, actually, I saw the documentary recently. So the first thing he does as everybody's getting off the boat is he's wearing gloves and he's looking at all their people with their hands, so he can spread out their hands. One of the most common things you see is scabies. So what he's looking for, if you see the documentary, is web space involved. So that's one of the common areas for scabies to involve. So you look at the web spaces, you look at the genitalia, and those are the areas where you see linear pustules or linear vesicles, and those are burrows. So that's where you want to scrape for the mite. So anytime you're suspecting scabies, look for burrows in the web spaces and look for involvement on the genitalia, so the nipple area and the genitalia. The itching is more at night, usually with scabies. That's another key thing to remember. There's usually more household members involved. And this is one of the things where you look at the rash first and then you shake hands. Otherwise, it will cause you to be itchy. Ulcers from the tropics, we looked at echyma caused by Staph aureus, and then we looked at other forms of ulcers like Bernoulli ulcer. So again, you look at the geographic setting and then what the ulcer looks like, and you have your differential. Streptococcal ulcers have a whitish exudate usually. Echyma, again, has a permanent exudate. More pictures of echyma. I just wanted you to see lots of pictures. Treat this with anti-staph antibiotics and topical antibiotics. How many of you have used gentian violet? Okay, that's great. So this is a cheap, effective treatment that's widely available in Africa and other tropical countries. You use 0.5% of gentian violet. You actually even have nurses who are trained to tell patients how to dilute it, and recently it's actually shown to have activity against MRSA. So just a really good thing to remember that this was something used years and years ago, and when I called the pharmacist up in Chicago, and I guess the Connecticut people will get to know me, they're like, nobody's asked me for that in years. So cheap, effective, and you can use this when you're stationed maybe in these areas. So this is another type of ulcer, echyma. And then grayish exudate, really rare, but diphtheria actually can cause ulcers too. This is Bernoulli ulcer. So in Bernoulli ulcer, seen most commonly in West African settings, it's got undermined borders, and I'll show you that in the next slide. So petechial, so non-blanching petechial eruptions in the tropics, dengue, viral exanthems, and rickettsial rashes can cause petechiae sometimes. Also linear lesions, cutaneous larva migrans, larva recurrence caused by strongyloides, jellyfish eruption can cause itchy linear lesions also. This is cutaneous larva migrans. Again, one of the things with dermatology, another key thing is look at the rash from far away first and then kind of hone in. So you see big picture and then you hone in to see the morphology. So from far away, linear lesions, lots of linear lesions. The patient has scratched these because these are itchy sometimes, so these are secondarily infected. Again, linear cutaneous larva migrans again. This is again cutaneous larva migrans, but in this case, the patient had scratched it so much that it's scabbed, but you still see the sort of pigeonous track. This is larva recurrence because of strongyloides streptoralis. Nattostomiasis. So this also has a cutaneous larva migrans stage. You might have covered the triad for cutaneous larva migrans: fever, migratory swelling, and peripheral eosinophilia. This picture is actually by a dermatologist in New York, and it was a patient from Vietnam who had eaten snake and frog and had some snake wine, which is the equivalent of Viagra, I've heard, in Southeast Asia. So this is a picture seen right in New York City by dermatologists there. So nattostomiasis. Linear lesions, jellyfish stings. This is the mantra, I think, for this course, which I really love this, teaching in tropical medicine courses, and that's all you need to, I think, know why you're memorizing incubation periods and all that stuff. And you can always look that up also. Why did this person from this case get these symptoms at this time? You ever had that look? Yes? Hopefully after this lecture it's going to be easier. So let's travel to Peru. Rather, this patient actually was seen in Chicago. Peru is absolutely beautiful country, and Machu Picchu is always on my bucket list. Has anybody been there? Machu Picchu. Great. It's absolutely beautiful. So cardiomyopathy, received cardiac transplant in Chicago, and post-transplant, the dermatology service was called because this patient developed these pink subcutaneous nodules, and the consult service was having fever, inguinal lymphadenopathy, and on examination, these were the nodules seen subcutaneous with a purpuric center. So in dermatology, how do we tell if something's dermal versus subcutaneous on exam? So dermal nodules, because they're in the dermis, are more well-defined usually. So subcutaneous, because they're deeper, they're more ill-defined. So when we see subcutaneous nodules, we think about something involving the subcutaneous fat. So infectious or necrotic. So in this case, that was a differential. Why do we differentiate? Because in subcutaneous nodules, we want to get a deeper biopsy that has fat also, which was done in this case. So we did a biopsy. We published this also, ended up, so this is a close-up subcutaneous nodule, and the sick patients, so the transplant patients with this, we think of infectious causes. This later on, they became dusty. And then, on the pathology, within macrophages, this kind of linear, wavy, intracellular element was seen. Does anybody know what this is? The patient is from Peru. Excellent. Yeah, it was Chagas. And actually, nobody thought that cardiomyopathy was caused by Chagas before the patient got the transplant. And after the transplant, the patient was put on immune suppression, and Chagas reactivated. So in reactivated Chagas, you can actually get subcutaneous nodules. I always put this picture in this lecture. It's because when you're putting your patients on biologics, prednisone, or transplant patients, always think about where the patient is from. If you want to pre-treat them with, suppose, for spondyloides, you want to pre-treat with ivermectin or something. So Chagas was the cause of this patient's cardiomyopathy. But people, in retrospect, when they thought of that was the cause for his cardiomyopathy. It was idiopathic to that point. So this was Chagas, and those were amastigotes within the macrophages. So that's the non-flagellated form. So the treatment is benzimidazole and nifurtimox, as I'm sure you've covered in this course, available through IND from the CDC. So trypanosomiasis, and Chagas is American trypanosomiasis. The disease was named after Carlos Chagas, and the parasite is Trypanosoma cruzi. The transmission is through the reduced bug or the triatome bug. And there's various methods of transmission for Chagas, and organ transplantation is another one. Blood transfusion and foodborne is being reported more and more recently. So as dermatology residents, dermatologists, and of course this course participants also have to memorize what the bug looks like. So this is the reduced bug, also called the assassin bug, the kissing bug, has various names. And as of 2006 December, all blood in the United States is screened for Chagas. So that's something interesting to know. Also an interesting thing that hasn't been deciphered yet is that in transplant patients or solid organ and bone marrow, the Chagas reactivates, it causes those subcutaneous nodules, but in HIV patients, it actually causes an encephalitis-like syndrome. Acute phase is 1 to 2 months, and that's where you get a chagoma that can be at the site of the bite of the bug, and the notorious Romanas sign, which is the unilateral violaceous periorbital edema. This one poor child is in all dermatology textbooks, as the sign for Romanas sign. So it's unilateral violaceous edema usually. After the acute phase, which lasted about 4 to 8 weeks, this is where it becomes tricky, it goes into the chronic phase. And this is where people can enter into that asymptomatic cardiac or digestive lesion form. So again, different regimens have been shown to be effective for reducing parasitemia. And this shows the distribution map for the blue for American trypanosomiasis and T2 and the yellow and purple and the map of Africa actually show African trypanosomiasis distribution. African trypanosomiasis, one of the most common lesions is a chancre, usually on exposed areas. And it's usually painless and can have an eschar. This is the next morphology I'm going to show you. So there's an ulcer at the distal edge of the arm, right? And then you've got these nodules kind of in a linear fashion. This morphology used to be called sporotrichoid. The more contemporary name is lymphocutaneous. So lymphocutaneous pattern or sporotrichoid pattern. So when you see this, the most common things in the differential for this is M. marinum, Mycobacterium marinum, in somebody who's been working with fish tanks, also called fish tank granuloma, sporotrichosis, leishmaniasis brasiliensis, and nocardia. And then you have the uncommon causes. So just remember that morphology, lymphocutaneous or sporotrichoid is interchangeable. So leishmaniasis, and I have lots of pictures of leishmania for you because I remember when I worked at the VA, this was one of the rule out leishmaniasis. You used to see a lot of patients coming back from Afghanistan and Iraq. So leishmaniasis, the most common areas depends on what species it is. You can have the Old World, New World classifications, you have the Tropica, and the major forms in the Middle East and Africa, and then you have the New World, the Brasiliensis and Mexicana in Central and South America. So classic leishmania ulcer is usually rolled borders, exposed areas, and usually self-heals. So that's the most common presentation for cutaneous leishmaniasis, especially in the Old World. So this is kind of following that lymphocutaneous pattern. Again, ulcers and nodules, exposed areas, sporotrichosis. So named after actually a British Army physician, Leishman, and he was the first to discover this in the spleen of an Indian patient who had visceral leishmaniasis probably. It's known by various names, Baghdad boil, Delhi boil, Lahore boil, that's a city I grew up in, Oriental sore. So it's a pretty old disease. And by skin biopsy, if you do catch the parasites, we show the amasculophorin and light microscopy in tissue. I bet you guys have to learn this, what it's transmitted by the sandfly species, Phlebotomus and Leucemia. Leishmania infantum is a species that was reported quite a bit in Eastern Europe, especially in HIV patients. This is from a patient from Afghanistan. This is the classic lesion for leishmania and what you put in your head for patients in Afghanistan. The rolled borders, the exposed area, and the ulcer. So self-healing, usually. On the air, leishmania mexicana, also called Chapero ulcer. And the mainstay of therapy, you can actually, dermatologists can use liquid nitrogen for 1 or 2 lesions of prior therapy. However, IV pentostam is recommended for multiple lesions, and patients have to be admitted sometimes. That's sodium stibogluconate. I just wanted you to know that in some countries, they actually do intralesional pentostam. For example, in the UK, intralesional sodium stibogluconate is done also. Just a few pictures of mucocutaneous lesion now. So this can be very disfiguring. This is mostly seen in the New World species also. Infiltrated plaques on the face. When you see this, mucocutaneous lesion, Central and South America. Again, lots of pictures I put up mucosal leishmaniasis to show you how disfiguring this can be. And this is the intralesional injection being done. This is a picture I took of a patient in London actually, where a tropical medicine physician was doing intralesional pentostam. Patient had just 2 lesions, 2 nodules on the arm. But they still admit the patient even though they do intralesional for cardiac monitoring. So amoebiasis, moving on to another parasite. So Amyloidosis is the classic dermatologic morphology you'll see is perianal ulcers in somebody who had amoebic dysentery. And these can be pretty huge ulcers, especially in somebody who's immunosuppressed. This is an interesting case that actually on biopsy showed a camp amoeba. The patient had been swimming in freshwater lakes. So I just put that here for your interest. Moving on to nematodes. So, filaria. And this, I'm sure the whole crowd is very familiar with the skin manifestations for filaria. And this is pretty impressive when you see it. And because of the huge lymphatic blockage by the nematodes, you can actually see the change, which is called elephantiasis, which I think is really unfortunate if you say it in front of the patient. So, so that's huge swelling. This is very late stage filariasis. So caused by various forms of mosquito species, and you can get scrotal swelling, and this is very, very late stage. You actually have, in South India, you have clinics, Ayurvedic centers that actually, I call it very nice, they do massage to increase lymphatic flow. So I call it as a really good holistic treatment that they employ for filaria patients. Another type of nematode, onchocerciasis. What's the skin manifestation for onchocerciasis? Well, first let's see the distribution. Again, mostly Central Africa and parts of West Africa. The nematode is Onchocerca volvulus. So the skin finding can be subcutaneous nodules called onchocercomas. It's again called river blindness, as you all know. Late stage onchocerciasis can cause, after because it's so itchy, it can cause vitiligo lesions. The patients scratch their skin so much that you have depigmentation. So when you see a patient who's very itchy from that part of the world with vitiligo-like lesions and skin that is thickened, think about onchocerciasis. I think that's sort of one of the take-home messages. Vitiligo-like lesions, very itchy patient with thickened skin. Think about onchocerciasis. This is lichenification. So lichenification means any patient who has itchy skin. So with eczema, with onchocerciasis, with scabies, patients scratch their skin so much that you see the skin lines being accentuated. This is the worm being pulled out of an onchocercoma. Loiasis, so that's Loa Loa, another nematode. The distribution for Loa Loa, again, is West Africa. And that's the worm on a day blood film. So filaria is usually present on a night blood film. And the swelling here on the dorsal hand for Loa Loa has a very classic name. It's called Calabar swelling. So named after the coastal Nigerian town where it was first documented. This is spread by the chrysops fly or the mango fly, and that red on the African map shows you the classic distribution for Loa Loa. One of the most common things you'll see, how many of you have seen cutaneous larval migrants? So this is travel clinics, this is like a walk-in diagnosis, and it's unfortunate the reaction a patient has. There's a worm in my skin, are you kidding me? Make it die, make it die. So you see students from beach vacations, people coming back from tropical vacations or tropical assignments. So most commonly on the feet, walking barefoot and getting inoculated. There's a picture I took in Malawi of a child. You see this serpiginous track. And then other elements, so that one is trichinosis, so skin manifestations as opposed to Romanes sign and trichinosis, you get bilateral periorbital edema, and in the very sick patients you can see splinter hemorrhages. For the life of me, I cannot say this, dracunculiosis. I always try to say this. So caused by Dracunculus miniensis. So affliction by little dragons. So this is the classic picture you have of somebody rolling up the worm on a matchstick or a stick, very painful, usually present on the lower legs. And the Carter Center is famous for the near eradication of this condition. Which just requires water being filtered properly so that the fleas that are infected with the larvae are filtered. And you can see it's a amazing from 1986, 3.5 million cases to 126 in 2014 and under less than 50 last year. So this is one of the great successes of tropical medicine besides smallpox. With this, Pakistan was one of the first countries to stop transmission of guinea worm disease. I think this is again in tropical medicine. We find when can we get eradication when there's only one definitive host. So in guinea worm, the only definitive host of the disease is humans. So that's why it was possible by education and by filtering water. Trematodes. Flukes, have you guys seen these in your microscopy sessions yet? Schistosomes? Okay. So this is where I spoil swimming for people in freshwater lakes. So Lake Malawi, which is one of the most beautiful places I've seen, and I work in Malawi quite a bit, and I have never been swimming or put my feet in the water. So whenever the students go in the water, there's praziquantel available like widely in the drugstore, so at your own risk. So this just shows the distribution of the different species of schistosoma, and you can see in Africa there's schistosoma hematobium and mancini in the yellow and blue, and those are the ones most commonly seen. So the rash with schistosomes when swimming in freshwater lakes is exposed areas. So it's also called cercarial dermatitis. So that's the other name for schistosomal dermatitis. So it causes like an irritant reaction, and the treatment is actually symptomatic with topical steroids and antihistamines. This is a patient in a student who was seen in Chicago. Who is a Peace Corps volunteer. That's another group that's predisposed to sometimes tropical infections, especially if they're posted in such areas. And whenever you see itchy bumps in the scrotal area in patients, one of the first things you should think about is scabies. So this was great. The scabies prep was negative. He was nevertheless still treated for scabies, came back, and then ended up having a biopsy. And this is rare, and this was published. So this was seen an egg with a terminal spine. So at that time, the resident hadn't taken the history that 3-4 years ago, the patient was in the Peace Corps and had been all over West Africa and had been swimming in freshwater lakes. So the egg sort of found a dead end, and a foreign body reaction formed around it. So this is not one of the common manifestations. I just put that in there that in retrospect, the history was taken after seeing the biopsy that this could not come from Chicago. So where were you 2-3 years ago? So hematobium. So hematobium has a terminal spine. So that's swimmer's itch. So swimmer's itch, cercarial dermatitis, exposed areas. Why do I say this? Because as opposed to sea waders eruption, which is caused by swimming in the Caribbean, Florida, Gulf of Mexico, sea waders eruption actually happens under the swimsuit. And this is caused by jellyfish larvae. This is something you'll see in people coming back from even these tropical areas. This is again treated by topical steroids. So sea waders eruption, covered areas, cercarial dermatitis or swimmer's eruption, exposed areas. So that's another sea waders eruption, bathing from distribution, the treatment is the same. So in viral, I made a whole section on HIV skin disease. Why I did that is because anything you see in immunosuppressed patients sometimes has a more dramatic presentation than usual. So this is zoster, again vesicles in a dermatomal distribution. This is one of those things when the patient walks in and they haven't been tested for HIV, and you just look at the patient, you're looking at your patient as a whole. They might be presenting with something else, like for the patient presenting with dry skin. This bitemporal lipoatrophy is sometimes a presenting sign of HIV. So when you see this, you want to test your patient for the virus. So this patient ended up being positive. Then eosinophilic folliculitis is an acneiform eruption on the face and the upper trunk that's itchy. In HIV patients, HSV can become more chronic and ulcerative. So in HSV ulcers, when you see the vesicles, they're grouped. When you see the ulcers, you have scallop borders. Even in your inpatients with D-cubes, with decubital ulcers, always look at the border also, and you won't miss an HSV ulcer with a scallop border. So sometimes we're called for D-cubes and they're HSV ulcers, perianal anal ulcers. Verruca can be more extensive, more hard to treat in immunosuppressed patients, so in this case, clustered together. Disseminated cryptococcosis can cause ulcers, but more often the umbilicated papules. And drug reactions. So this is toxic epidermal necrolysis. If you remember, we went over the morbilliform eruption at the beginning. When you run your hand over that eruption or the erythroderma, this is how the skin peels off in toxic epidermal necrolysis, and you see the dermis, and it looks like a burn. So these patients need burn like unit care, and that's the skin rolling back. You face your hand and the skin kind of curls back. This is called Mikulski's sign in Stephen Johnson's and toxic epidermal necrolysis, and you see conjunctival injection. So those red eyes. And this is where you examine the mucosa in the morbilliform eruption or the erythroderma, and this is the patient you want to admit then. And Stephen Johnson's syndrome. So these are the worrisome reactions, and your top culprits are sulfur drugs. So sulfur drugs, antibiotics are your top medicines that you think of, and anticonvulsants. Hemorrhagic fevers, these pictures are courtesy of one of my professors who worked on Ebola and Lassa in the 70s. So you can see the quality is great, but pharyngeal erythema can be seen in Ebola. And then late stage, you can get basically endothelial cell death and purpuric eruptions all over the body. And then with Lassa fever, just called blood diamond virus, good movie. Lassa fever, hemorrhagic conjunctivitis, and then you can see petechial and purpuric eruptions in both Ebola and Lassa as a late stage presentation. Moving on to another viral illness, so we've covered Lassa fever. At that time, in the early 2000s, dengue was being reported in Keys, Puerto Rico, and then I have a picture of a prairie dog here. Anybody know why? For what? For monkeypox. So there was a paper in 2003, actually, and this reads like a Disney movie, like Zootopia or Madagascar, where there's a shipment of Gambian giant rats and prairie dogs coming from West Africa, and there was an ill Gambian giant rat that infected the prairie dogs. The shipment arrived in the Midwest. People got these animals as pets, and the prairie dogs were infected with monkeypox. And we had an outbreak of monkeypox in the Midwest. And monkeypox actually looks like vesicles, so vesicular in nature, and can be cutaneous inoculation, and it's usually the extremities, so the exposed areas, and it's clustered vesicles. And the treatment is usually symptomatic, and the do biopsy, but mostly it's PCR for establishing the diagnosis. So ORF, also called by pox virus, has different stages that I think you guys probably need to know. I remember it being on my MTM test. So these are the various stages: maculopapular. Notice how I use that term. So I think it's mostly like a flat macule or a papule at the beginning stage for ORF. Then it becomes targetoid with a central dusky center to weeping nodule. And notice who gets this: shepherds, butchers, veterinary surgeons, sheep shearers. Does anybody know at what time of the year in the world there's like the outbreak of ORF always in a certain part of the world?
Or springtime.
Why?
When you shear sheep.
So sheep shearing, and another actually places when the Muslims celebrate the Hajj or the pilgrimage to Mecca, and sheep and goats are sacrificed. So there's big outbreaks of ORF in those countries at that time also. So exactly sheep shearing and season, and then the pilgrimage time. And these two are really two key slides to memorize, and after this we'll take a break. Smallpox versus chickenpox. So both vesicular lesions in smallpox, they are more monomorphic. All of them seem to be in the same stage, and with smallpox, they're clustered on the face and the distal extremities, the vesicles. In chickenpox, it's more of a truncal distribution. And I'll show you the picture. So this is chickenpox in a child, and you can see the vesicles are kind of, kind of spaced out, they're sort of tight. Usually there's accompanying fever or myalgias. This is smallpox. You can see how it's so concentrated on the face. It all looks like it's in the same stage, so that's why the term monomorphic is used here. So the incubation period, 12 days, and the high mortality associated with smallpox. Again, smallpox day 5. See how clustered around the face it is? Chickenpox rarely does that, and on the extremities too. Again, uniform, same stage. Depigmented scars. Smallpox usually more inflammatory and more scarring than chickenpox also. This is the scarring after recovery from smallpox. Splinter hemorrhages seen with disseminated smallpox, and this is complicated hemorrhagic smallpox. This is a picture to keep in mind with smallpox. Many vesicles, all of them almost look umbilicated sometimes, the vesicles with the central crust. Smallpox vaccine injection site. This is a more exuberant reaction. And then not to obviously have contact with patients with eczema who have barrier dysfunction. We actually had a case of a kid with eczema also where the dad had been vaccinated, I think, and the kid presented with eczema vaccinatum. So you can get smallpox lesions within the eczema patches, and that's a very serious condition. Again, vesicles massively distributed on the face.